Good evening, everyone. We'll start in 1 minute. Good evening, everyone. Today, it's my privilege to introduce our distinguished expert in the field of radiology and musculoskeletal imaging. Please join me in welcoming Dr. B. Gurumurthy, MD in radiodiagnosis and currently serving as an assistant professor at JIPMET, Puducherry, one of the India's most reputable medical institutions. Dr. Gurumurthy is a Karnataka state rank holder in MD radiodiagnosis from RGUHS University, an achievement that highlights his academic excellence and commitment to his profession. He has delivered numerous invited talks, especially in the area of MSK imaging, and has contributed significantly to research with over 20 scientific publications. He has also completed an MSK MRI fellowship focused on shoulder and knee imaging, along with an ICRI IRIA certified advanced course in MSK ultrasound. His core area of expertise lies in the musculoskeletal imaging, and he is an integral member of the Institute's multidisciplinary bone tumor board, playing a key role in complex diagnostic discussions. Today, we are truly honored to have him with us. Please join me in warmly welcoming Dr. B. Gurumurthy. So, Dr. Gurumurthy, over to you.
Thank you, ma'am.
Now you can share your slide, please.
Sure. Okay, shall I start, ma'am?
Yeah.
Yeah. Good evening, everyone. I am Dr. Gurumurthy from JIPMET Puducherry. So I'll be discussing about bone tumors today. So we'll go through these headings. We'll focus on exam-oriented approach to a potentially neoplastic lesion. So how we are going to approach a bone lesion in a systematic way. And in between, we'll have few spotters or questions so that you can answer to them and answer to the specific question in your chat box. And we'll discuss those also. Then after the discussion, we'll assess few exam cases and we'll tell how to write in your exam, what all to utter, what mistakes to avoid. Then we'll discuss few common pitfalls like minor errors which we'll end up doing and which on whole can result in wrong diagnosis also. So overall, we'll try to focus basics and make the foundation strong. So any exam, anywhere, you will definitely have an exam case on bone tumors. This is sure. Like 99.9%, any exam, there will be a bone neoplasm case. So if your foundation is very strong, it will be very easy to approach the bone lesion. And the most important question is whenever you get a bone lesion, you have to tell whether it is a tumor. If it is a tumor, you have to tell whether it is aggressive or non-aggressive entity and what is the next recommended step. So if you know the basics, if you apply those basics in a systematical, logical way and reproducible way, it will be very easy to answer these three important goals in a case of bone lesions. So why I stress on logical is there are two entities. One is the bone neoplasm and the host bone. So these the neoplastic lesion will be undergoing or making some changes in the host bone, and the host bone will be trying to concise, or it will try to prevent the neoplastic lesion from growing. So basically there are two things happening. The neoplasm will be showing some changes and the host will be trying to contain it. So these two changes or the biological features which are appearing can be picked in our x-rays. So x-ray radiography will be the first and optimal imaging modality. So your eyes see what your mind knows. So you have to train your mind before seeing any modality or any pathology in any system. The same way you train with what all to be seen in bone neoplasm, so that you pick up those things, apply those in a systematic logical way to come at a differential diagnosis or a definitive diagnosis. So we usually follow a three pillar approach where sorry, first is the age at presentation, second is the location, third is the radiological features. So what are the imaging features here on the X-ray? So the how much importance we give to the imaging features, the same equal importance has to be given to the age of the patient and the location of the tumor.
இல்ல ஐஸ்வர்யா ஏதாவது வெயிட் ரிடியூஸ் பண்றாங்க
Hello.
கல்யாணத்துக்கு.
So I request everyone to mute. And so that was the three pillar approach. But at the end of the your academic sessions, with so many systems, we'll be finding very difficult to remember all. So we use this mnemonic LECZ MPO, so which I refer during my post graduation referring to radiology without TS book. So the L signifies the location or lytic, basically the density of the lesion. E comments about the expansile or non-expansile nature of the lesion. C tells whether the lesion is in the center or eccentric location. Z, which is the most important feature, tells about the zone of transition. M stands for matrix mineralization. P stands for periosteal reaction. C is the cortex status, whether there is any endosteal scalloping or cortical distortion. O stands for other features or other lesions. Other features include soft tissue components and pathological fractures. So we will club both. We will see the three pillar approach along with the mnemonic. So starting with the age at the presentation. So this is the most important clinical information. So we divide the age group into two: less than 30 years, more than 30 years, to simplify the process. So when you take age group less than 30, that is a young patients, most of the lesions, if you see in the list, are benign. Only two are your primary neoplasm. One is your osteosarcoma, the other one is your Ewing sarcoma, and don't forget about the metastasis secondary to neuroblastoma, which will occur in pediatric age groups. So whenever you encounter a patient of less than 30 years, if it is an aggressive looking tumor, suspect osteosarcoma, Ewing's, neuroblastoma, metastasis. The rest all are your benign entity. And when you're dealing with the patient less than 30, always see for the physis of the bone, whether the growth plate is fused or not. So that will still further narrow down your differential diagnosis. Next, coming to age group of more than 30, if you see the list, most of the lesions are malignant aggressive lesions. So whenever you encounter adult or elderly patient, always think of malignancy more than that of a benign etiology. So this is why age is one of the important first pillars, where we will, based on the age, we will try to give a set of differential diagnosis. So second pillar is the location in the body. So we'll be given a set of radiographs and cross-sectional images. The first role is to find where the lesion is located. After checking the age, we have to locate where the lesion is. So whether it is in the axial or appendicular skeletal structure, whether it is in the flat bone or in the long bones. So in your exams, most of the cases will be in the long bones. So once you localize the lesion, next step is to see where it is in the long bones. So longitudinally, it can either be in the epiphysis, that is the ends of the bone, or it can be in the diaphysis, which is the center of your shaft, or in the metaphysis, which is the area between your diaphysis and epiphysis near your growth plate. So this will further narrow down your differential diagnosis. The other one is localization in the transverse axis. So if you cut open a bone, if it is located in the center of the medullary cavity, it is known as a central medullary lesion. And if it is in the off midline, which is not like in the midline, or if it is just in the off midline, left or lateral aspect, you call it as an eccentric intramedullary lesion. And if it is purely epicentered in the cortex, you call it as an intracorticular lesion. And if it is on the surface, you call it as an juxtacorticular surface neoplasm. So we'll club the longitudinal location and the age now. It will further, as I said, it will further narrow down your differentials. So I usually prefer remembering epiphyseal lesions and diaphyseal lesions because metaphyseals will cover a lot of neoplasms. So if you remember the epiphyseal and diaphyseal, the remaining will be your metaphyseal lesions. In the age group less than 30, before the growth plate is fused, if you find any lesion in the epiphysis, think about chondroblastoma. And in younger age group, if you see any diaphyseal lesions, think about Ewing sarcoma, osteoid fibrous dysplasia, and eosinophilic granuloma. Whereas when coming to elder patients, so same epiphyseal lesions, if the growth plate is fused any age, usually you will suspect GCT. And diaphyseal lesion, elderly patients, whatever is it, usually it will be malignant neoplasms like metastasis, multiple myeloma, lymphomas. Remaining will be your metaphyseal lesion. So I usually prefer to remember epiphyseal and diaphyseal lesions. So now we'll see one by one regarding the transverse location of the lesion. So we'll see how we explain or describe in an exam. So this is a frontal radiograph of distal thigh showing a centrally located intramedullary lesion. So before committing, you should see the physis is fused or not. So this is a distal femur. You can see the physis is fused. So whenever you describe, you have to state that this is a frontal radiograph of distal thigh of a skeletally mature patient showing the lesion centrally located in the intramedullary cavity. Next, now there are two radiographs. So one is frontal radiograph, other is lateral radiograph. So you have to describe as an, these are the frontal and lateral radiographs of distal thigh in a skeletally mature patient with the lesion located in the off midline. So there is an eccentric location of the lesion, which is the E of our mnemonic. Next, so similarly, this is a frontal radiograph of the arm. You have to mention the side. This is a right arm. The physis plate is not fused. So this is an immature skeleton. And the epicenter of the lesion is located in the cortex, suggestive of an intracorticular location. So next, similarly, if you this the frontal and lateral radiographs of a skeletally mature patient, if you see the frontal radiograph, it appears as though it is in the center and even in the eccentric location of the medullary cavity. But if you see the lateral X-ray, you'll be able to appreciate the surface location of the tumor rather than an intermedullary location, which is apparent as in the frontal radiographs. So you have to be very careful whenever there is long bone. Definitely, they will be providing both the views. So to summarize the location-wise specific tumors, this is a summary table taken from EOCOM. So where they have divided the lesions into epiphyseal origin, metaphyseal origin, and diaphyseal origin. So as I said, remember the epiphyseal and diaphyseal, rest all are your metaphysis. And this is the table where it shows the commonest location of most of the tumors. It's very difficult to remember, but one sentence, if I want to tell, most of the tumors will be arising either from the femur or humerus. Almost all will be around humerus, around the knee joint, especially in the femur. So these are the commonest locations of the bone tumors. So now we'll test whatever we have seen till now. So there are two radiographs now. I request everyone to reply in the chat box. So I want you to identify the maturity of the skeleton, comment whether it is skeletally mature or immature. Also comment about the longitudinal and transverse location of each lesion. So image A, whether immature or mature, where is the exact location. Similarly for B. So I request everyone to comment. No need to describe the lesion and all, just skeletal maturity, location. So we'll give 30 seconds so that most of you comment about. Yes, I don't know the diagnosis. Just stick to the questions. Yes, most of you have answered. So if you take the image A, so this is a frontal radiograph of your knee joint with distal thigh of a skeletally mature. You're not able to make out any growth plate. It's fused. So it's a skeletally mature radiograph. And the location of the lesion is in the epiphyseal region. So remember the term I used, epiphyseal region, not just epiphysis, epiphyseal region, because it's a fused mature skeleton. So whenever it is an fused mature skeleton, just mention as region, not as just an epiphysis, metaphysis, diaphysis. Preferably use the term region. So here predominantly it is in the epiphysis with some amount of extension into the metaphysis also. And coming to this side, so this is a frontal radiograph of the shoulder of a skeletally immature patient. So the growth plate is not fused and the lesion is in the metaphysis. So similarly, we will see the third example. So this I'll try to tell. So there is an lateral X-ray of the thigh and longitudinally transverse location has to be commented. So if you see this whole central part of the medullary cavity is involved, so there is a central intramedullary lesion, and whether it is epiphysis, metaphysis, diaphysis, you can see the metaphysis and epiphysis are well away, so it is in the diaphysis and more towards the proximal part of the bone. So it is probably in the proximal diaphysis. So now coming to the major pillar, that is the radiological features pillar. Third pillar is the radiological features pillar. We'll start with the number of the lesions, whether it is solitary or multiple. So after seeing the age, location and all, we'll start analyzing the radiograph and see how many lesions are there. So if it is solitary, usually most of them will be a benign phenomena is what we consider, and a benign primary phenomena. And if it is multiple, usually we'll think whether there is metastasis, multiple myeloma, or any metastasis, non-Hodgkin's lymphoma kind of picture. But you should be aware that there are multiple benign lesions which also can present as an polyostotic form. So for example, these are all your spotters which you will get, like multiple enchondromas, Polius disease, multiple enchondroma, hemangiomas, morphosis, multiple osteochondromas are hereditary multiple exostosis, multiple enchondromas and osteochondromas are metachondromatosis. So these set of lesions which are all multiple in number, but they're all benign. But you have to be very careful with this set of lesions because they are more prone for malignant transformations. So there are few examples of multiple lytic lesions, multiple sclerotic lesions, which should be aware of. So basically, when you are given X-ray, you have to state whether it is a solitary lesion which are provided or there are presence of multiple lesions. So next, moving further, you have to comment about the density of the lesion. So whether it can be lytic lesion, sclerotic or mixed. So basically, a lytic lesion is one which is very lucent in nature. The density is less than that of the normal bone. And you will be able to appreciate the internal structures, if at all, if any matrix and all, which we'll discuss later. So to start with the radio density of the lesion, see whether it is lucent. Lucent means lytic. So there will be three types of lytic lesion. One is geographic type of lytic lesion where the lesion size is usually more than 10 mm. Next is the moth-eaten type of lytic lesions. They are very small lesions, punctate lesions 2 to 5 mm, and permeative type of lesion, which are usually 1 to 2 mm. So when you encounter lytic lesions, this is the universal mnemonic which everyone follow. This is a set of differential diagnosis for lytic lesions. Next, coming to sclerotic. Sclerotic will be more dense. It will be radio opaque when compared to the adjacent normal bone, and they will have only few set of differentials like osteoma, and bone islands, blastic metastasis, Paget's disease. So these are the few common differentials for radio density. Next, coming to mixed is the pattern where there will be both mixture of sclerotic and lytic lesions. So moving further, so again we'll test ourselves to include whatever we have learned and reinforce again. In this X-ray, I would like to you people to comment on the location of the lesion, where exactly is the location and the density of the lesion. So take 20 seconds and try to comment where exactly is the lesion. So see both the X-rays, a frontal radiograph and a lateral radiograph of knee with the distal thigh is given. And it is a skeletally mature patient. The growth plate is fused. Comment about the location of the tumor. So where exactly it is located? In longitudinally, if you see, it is closer towards metaphyseal region. Transversely, if you see, if you club both the surfaces, most of them have answered it correctly. It is in the metadiaphyseal region, epicentered in the metaphysis, and it is along the surface, that is the juxtacortical origin of the lesion. Next, it is a solitary lesion, and the density is more than that of the adjacent bone. So it is a radio opaque or radio dense sclerotic kind of a density. So most of you have answered it correctly. So we'll move further. So we'll be reinforcing with few examples like this, and we'll try to recall what we have learned and apply. So zone of transition, a margin of the lesion. This is the most important radiographic features which tells about aggressiveness of the lesion. So this, a basic fundamental thing is, we will apply this to a lytic lesion, not sclerotic lesion. So as I said before, lytic lesion will be three types: geographic, moth-eaten, permeative. Geographic will be a larger than 10 mm, that is more than 1 centimeter. Moth-eaten will be 2 to 5 mm, permeative usually in the range of 1 to 2 mm. So when you encounter a geographic lesion, you have to see how the lesion is with respect to the adjacent bone, whether it is well defined, whether it is well defined, whether it's well demarcated, and you are able to appreciate it separately from the normal host bone. So this is an example where you are having a geographic lesion with a border. Okay, as I said before, the host bone and the neoplasm will be trying to tell most of the features to us. If a neoplasm is indolent and slow growing, our host bone has enough time to contain them. So they will start forming a boundary around the lesion. So this boundary or a wall which gets formed around the lesion appears as a thin or thick sclerotic rim around the lesion. So this signifies that the underlying pathology is indolent, slow growing entity. So whenever you see such cases where there is a lesion which is well demarcated, when there is a zone of transition, that is the difference between the pathological bone and the normal bone is well made out, you are dealing with a benign entity. So this, how you describe? You describe as a geographic lesion with narrow zone of transition showing a thin sclerotic rim. So your neoplasm and the host bones are trying to tell the features themselves. So you can see the lytic nature of the lesions with a thin sclerotic rim here. So similarly in this, if you see, there is a lytic lesion which is geographic in nature with a thick sclerotic rim. So this signifies that this is a benign entity we are dealing with. So next, geographic lesion, a narrow zone of transition with no sclerotic rim. Even if you get this kind of picture, that also signifies benign entity, benign pathology. So here also, if you see, there is a well-defined lesion, you are able to make out the differentiation between the pathological area and the normal bone, suggesting of a narrow zone of transition, but you are not able to appreciate any sclerotic rim. Fine. Even if this is seen, that also signifies it's a slow-growing benign kind of a pathology. But similar geographic kind of lesion If you are not able to make out the differentiation between pathology and the normal part of the bone, then we will call it as white zone of transition. So some people will be always thinking like only moth-eaten and permeative are the one lesions which will show white zone of transition. No, even a geographic kind of lesion can show white zone of transition, which you should be aware. And this, if you see, this also this suggests of an intermediate to aggressive kind of lesion, but this has chance of malignancy of nearly 50%. So we should be careful about this kind of lesions where there is a geographic large lytic area, but the zone of transition wide. Always suspect a locally aggressive neoplasm. Next are the common malignant or aggressive looking feature lesions. These are the moth-eaten appearance, which I said 2 to 5 mm. They will be with the margins being very rugged and hazy and ill-defined. So this signifies it's an aggressive pathology. It can be either a malignant pathology or it can be also seen in the osteomyelitis. Next is the permeator kind of lesion, which is still more aggressive, which will appear like tiny pinheads, like it will be around 1 to 2 mm in size or less than that. And you won't be able to appreciate the margin at all. It will be very vague, subtle osteopenic changes kind of thing in your pathological area, and you're not able to appreciate any zone of transition. So this signifies it's having wide zone of transition. This also implies it is an malignant lesion or aggressive kind of lesion, which can be also seen in osteomyelitis. So next, coming to the matrix mineralization. So the zone of transition will comment about the aggressive nature of the lesion. Matrix and mineralization comments about the histopathological component of the lesion on your X-ray. So most commonly we will be seeing purely lytic lesions without any matrix. Next is the osteoid matrix. So in SBC, ABC, GCT, most of the lytic lesions which you see, we won't be able to appreciate anything within the lesion. There won't be any matrix radiography which can be picked. So in those cases, you can just comment as no matrix seen. You can just mention as a purely lytic lesion, whatever septations are there, those you can comment, but doesn't apply to any part or type of the matrix. But if you see this X-ray, you can see a radiodense area. So this is the osteoid matrix, which tells that the lesion is predominantly having precursors of osteoid tissue. So between the tumor cells, there are osteoid components. This gives hints to what is a possible histological diagnosis of your case. Usually, whenever you see an osteoid matrix, usually it will be osteoid osteoma, and most commonly will be your malignant osteosarcoma. So your osteoid matrix will appear usually amorphous, cloud-like or dense area. It also can be fluffy, but it will be more uniformly amorphously dense area. Next is the chondroid matrix. So here you can see there are 3 different types of chondroid appearance. So either you will see dot stipple type of hyperdensities. These are nothing but calcifications, or you will see a popcorn like flocculent type of radio density microlobulated, which is typical of flocculent calcification. And the third one is the ring and arc type. So you'll be able to appreciate some rings and arcs, some linear dash, commas, all those things, densities within the lesion or bone. So those are nothing but ring and arc calcifications. So don't ever get confused with chondroid matrix or chondroid matrix with your osteoid matrix. Osteoid matrix will be cloud-like, amorphous, diffusely dense, whereas your chondroid osteoid matrix, whereas your chondroid matrix will be spickled. It will be like dot or dashes or R ring and R or like comma, or they will be popcorn like flocculent type of calcifications. So these will tell what is the possible histological component of your lesion. So apart from that, there are 2 more matrix. One is the groundless matrix on X-ray, which will appear as an haziness. Usually a fibrous matrix will show this type of appearance. Usually we'll see in a fibrous dysplasia. And next is your fat matrix. Fat matrix as such, you can't be commenting on plain films, but in spotters, you'll be able to see the intraosseous lipoma in the calcaneum with central heterotrophic or dystrophic calcification which occurs in the center. This is an features characteristics of intraosseous lipoma. But as such, fat matrix cannot be commented on X-rays in a bone. So we'll reinforce what all we have learned till now. So there is a frontal and lateral radiograph of the thigh. We are seeing in fused skeletally mature patient. So I would like you people to comment about the location of the lesion in the transverse position and longitudinal position. Comment about the density, what is the zone of transition and the matrix for this particular lesion. Yes, we have started getting the answers. Good, most of you have answered it correctly. Some are confused with the zone of transition. So we'll discuss this radiograph. So as I said, I will be repeating it so that it gets reinforced. This is a frontal and lateral radiograph of thigh of a skeletally mature patient. Then I will localize the lesion longitudinally. So this is in the metaphysis, that is proximal metaphysis. And the density of the lesion, it is lytic lesion. Coming to the zone of transition. So this is the trick now. If you see the frontal radiograph, it appears as though it is very well defined. Like there is a narrow zone of transition. You are able to, actually you are able to see the margin clearly. You are able to appreciate the normal bone and the pathological bone. But coming to the lateral aspect, if you see, the margin is very hazy or blur. You are not able to make out the zone of transition properly between the normal bone and the pathological bone here. So in this area, if you see, it's a wide zone of transition. So even in one view, you are able to make out the wide zone of transition that states that the lesion is aggressive in nature, and don't fall into trap with just a single view. Whichever view is showing aggressive nature, pick that aggressive nature on your X-ray and try to stick to that so that you don't get deviated. So this is basically a pitfall. You will be uh, there will be a small error in your judgment, and you will be deviating into a benign entity. And coming to the matrix, we are not seeing any dense austere kind of matrix. We are not seeing any speckled or dot dash or ring arc, all those kind of hyperdensity sustain of chondrite matrix. So there is no matrix in this case. So we'll move further. So next important radiography feature which will tell about the aggressive nature is the periosteal reactions. So as I said, the neoplasm will be showing its features. Our host bone will be trying to contain it. So when this neoplastic lesion induces some kind of intrinsic or extrinsic pressure over the cortical bone, the cortical bone will start showing some reactions. It will also try to contain the lesion. It will start, the normal cortex will get replaced by neocortex. It can form a single layer of periosteal bone as a reactive sclerosis to contain the lesion. So basically, the inciting factor, it will be depend on the inciting factor. If it is slow growing and indolent kind of a lesion, the host bone will have sufficient enough time to form a periosteal reaction and cortical thickening on one side. If the growth of the bone overtakes that of the host response, then the growth of the bone will eventually start progressing, and the pressure over the cortex will be more rapid than what the host bone can contain. So in that cases, you will be start getting aggressive kind of pictures like laminated, where the host bone will form a layer of reaction. The tumor process will supersede it. Again, the host bone will form a layer of periosteal reactions. So subsequently, you will have a multilaminated appearance, or there can be either any spiculated, which can be parallelly oriented, perpendicularly oriented to your neoplasm, or it can be angulated in case of sunburst, or it can elevate the one side of the periosteum and grow beyond the periosteum and result in a triangular edge of the lesions known as Codman's. So this is the increasing order of aggressiveness. So basically, whenever you an X-ray, after the first initial features what we saw, you have to comment about the cortex and the periosteum, whether it is an non-aggressive type of periosteal reaction or whether it is an aggressive type of periosteal reaction. So we'll see the few exams. Lesion in the cortex, usually intracortical lesion, we'll think of osteoblastoma, and there will be a reactive sclerosis or single layer of periosteal reaction to contain it. Since it is slow growing nature, a single type of single layer of periosteum usually seen. And on radiograph, you can appreciate in this X-ray, there is some irregular single layer of periosteal reaction on both the sides of the femoral metadiaphyseal region, suggestive of an non-aggressive type of periosteal reaction. Whereas in case of a aggressive pathology like sarcomas or even infections, there will be layers of periosteum layering of periosteum over the pathological area, giving an onion peel or onion skin type of periosteal reaction. Usually we will see this type of periosteal reaction in Ewing sarcoma and sometimes even in osteomyelitis. Then this is an perpendicular Heron type of periosteal reaction. So we can see spiculated bony spicules also, which is usually some part of mineralization, bridging mineralization along with the periosteal components. Or it can be divergent in the form of sunburst appearance. This also usually seen in case of osteosarcoma. Then Codman's triangle. So if you see, the lesion is trying to outgrow what the bone periosteum can contain. So it just gets lifted and appears and as an triangle piece of bone along the periosteum. So this is the triangle piece of the periosteum appearing as a triangle in at the ends of the margins of the lesion, suggestive of Codman's triangle. So same thing can be appreciated in this X-ray. So here you see a triangle shaped periosteal reaction at the margins. Think of Codman's triangle and hence an aggressive type of periosteal reaction. So again, we'll test ourselves. So we club all the findings again. Comment about the location, density, zone of transition, matrix, and the periosteal reactions. What all type of periosteal reactions are seen in this X-ray? So you can start commenting now. So take time. There are a few points to be commented. So see the radiograph. It's a frontal and lateral radiograph of forearm with wrist of a skeletally mature patient. Comment about the location. Where exactly is the lesion longitudinally? So if you see, the lesion is not in the metaphysis or epiphysis, predominantly is in the epiphyseal region. And if you see, the density is lytic. And what kind of lytic? Moth-eaten permeative kind of lytic lesion. The zone of transition, you're not able to appreciate it much. So it's a wide zone of transition lesion. What is the matrix? I'm not able to pick up any osteoid, chondroid type of matrix. So there is no matrix in this kind of lesion. And what is the periosteal reaction? So here we are able to make out bony spicules parallelly oriented. Here it is divergent. So there is aggressive type of periosteal reaction. There is sunburst, hair ornament. There are even Codman like triangular periosteal elevation at the margins of the lesions. And in this lateral aspect, you're able to make out multi-layered periosteal reactions. So basically, this entity has all the type of aggressive periosteal reactions. Even if you get a single type of aggressive type of periosteal reaction, think of aggressive entity. Either with the proper clinical context, suspect neoplasm or osteomyelitis. So coming to the final few important radiographic features, one is the cortical changes, what the bone shows. So endosteal scalloping is one of the important cortical involvement features. This is very important with respect to chondrogenic tumors, which I will discuss with a few examples. So basically, as I said, the host bone will start pressurizing the endosteum, then subsequently the periosteum, all those things. So when it starts pressuring the endosteum, it will start scalloping. So this is the endosteum. This is the normal thickness. You will start seeing reduction in the thickness resulting in a scallop. So this is nothing but the intrinsic pressure with the neoplasm gives. So the same thing can be seen here near the metadiaphyseal region, where there is a normal thickness of the cortex on medial aspect, whereas in lateral aspect, some scalloping is seen. So this signifies that there is a significant intrinsic pressure. The role of it is very important in chondrogenic tumors, which will I discuss later. Next is cortical destruction. So the lesion initially starts with the endosteal scalloping, which eventually will break the cortex and start extending beyond the cortex to have some extra osseous component. So this is another entity of aggressiveness. A zone of transition, periosteal reaction, cortical distractions. These three are very important radiographic features to comment about aggressive nature of the entity. So other thing is the bone starts just expanding. It will show just an expansile remodeling. So this is also the host response to the neoplasm. So there won't be much of cortical breach. There might be some small thinning, but the cortex medullary cavity itself appears as a balloon. So there is a cortical remodeling happening in this set of conditions. These are usually seen in benign entities. The cortical breach and the cortical scalloping, which occurs in chondroid tumors, those two are very important features towards aggressiveness. So others, soft tissue component. A presence of soft tissue component along with a bony lesion, you have to think of aggressive pathology. Whether a malignant neoplasm or infection, you have to suspect aggressive nature of the lesion. If the soft tissue is displacing the fat planes, as seen in this X-ray, think of neoplasm. If there is obliteration of the fat planes due to the soft tissues, you are dealing with infection rather than a neoplasm. So apart from these, other features are pathological fracture, presence or absence has to be noted, and even you should look for any other lesions are there, not just to stick to the primary pathology. You have to see other parts of the bone, whatever is covered or whatever is shown, you have to pick whether any other lesions are there. So these will help in picking up skip metastasis, skip lesions, all those things can be picked up. So even that has to be commented. Then always check the history whether the patient is a known case of any primary cancer. This is important even in the case of your routine day-to-day clinical practice. So these sums up your major third pillar, that is the radiographic features. This is a structured report from ACR Bondrad's criteria. So whatever we discussed with the mnemonic are covered in the your reporting template. So we can see the technique, all those things, patient demographic, age, and whether any known case of malignancy or not. Then coming to the findings. So location of the bone. So short axis, long axis, that is longitudinal and transverse location of the bone. Then you comment about the density. Next, the matrix. These two will tell the histological possibility of the lesion. Next is the margination or the zone of transition, periosteal reaction, endosteal scalloping, pathological fractures or soft tissue mass. These components will tell the aggressiveness of the lesions, which we discussed before. Then we have to tell whether there is any chance of impending fracture. So this is a structured reporting template by the ACR bone rats team. So now we'll assess few exam cases. So this is the most important part of our discussion. So what all we have learned, we'll apply to this case. We'll have a set of checklist. We'll enter those checklist. We'll come to a conclusion. Then we'll see how we are going to explain this in our exam, or how we are going to write and speak out during the Viva. So this is an image in a 17-year-old boy with the right-sided shoulder pain. So how we are going to start? This is a frontal radiograph. Already they have mentioned as 17. So on X-ray, you check whether the skeleton is mature or immature. So if you see thin sliver of line 5 is not yet fused, so it's an immature skeleton. It corresponds with your age, what they have provided. If you're not able to see, I'll zoom and give. So here you are able to appreciate the physis. Now we'll see the checklist. Patient age. So as we said, it's an immature skeleton. The location. So where exactly is the location? It's in the proximal humerus. So what is the transverse and longitudinal location? Longitudinal, if you see, it is involving the epiphysis and also the metaphysis. So it is an epimetaphyseal type of lesion. Whether it is located center or eccentric, if you see, most of it is in the eccentric compartment. It's not just center, even it is the placed in the eccentric part of the medullary cavity. Next, the density, it is more like a lighty kind of lesion. Next, the zone of transition. So if you see this, you're able to appreciate the narrow zone of transition. So this is a geographic kind of lesion with narrow zone of transition, and a thin sclerotic rim is seen. So this is telling that this is a benign entity, not an aggressive pathology. Next, the matrix mineralization. So you can see a dot kind of an arc kind of hyperdensities within the lesions. So these are your chondrite matrix. This is how your chondrite matrix appear. So don't get confused with the septas. Along with the septas, if you see a dot, dash, curves, commas, all those things, hyperdense areas within the lesion, always think of chondrite matrix. And to an extent, there is no obvious periosteal reaction in at least in this particular view. And if you see, there is a moderate scalloping is seen along the lateral aspect. And what are the other lesions? Any lesions are seen? No other lesions are seen in our X-ray. As such, there is no soft tissue mass. The muscle plane and the fat plane over it all are well made out. So we have our checklist here. We have filled the checklist. It appears as though it is a benign entity. So we'll come to diagnosis, or narrow down to the diagnosis, starting with the three pillars. One is the age, 17. Next is the location, epimetaphyseal region. So as I said, a less than 30 skeletally immature skeleton, epiphyseal lesion, your differential will be chondroblastoma. So chondroblastoma will have chondrite matrix, which is picked in our radiograph showing your chondrite matrix. Then the benign nature is reinforcing your features which you have seen in age and the location, where you are able to make out the geographic type of lesion with narrow zone of transition with a thin rim of sclerotic sclerosis. There is no periosteal component, there is no soft tissue component, there is no obvious any pathological fractures. Only some amount of endosteal scalloping is there, but there is no cortical breach. So to summarize all, how we are going to explain or write in your exams. So this is how you are supposed to, this is what as an examiner we will expert. So this is a frontal radiograph of right shoulder of a immature skeleton. There is a well-defined eccentrically located geographic lytic lesion in the epimetaphysis of the proximal humerus. The lesion exhibits a narrow zone of transition with a thin sclerotic rim and contains characteristic chondrite matrix mineralization. There is mild to moderate endosteal scalloping, however the cortex is intact. There is no periosteal reaction, no associated fracture, or no soft tissue mass. Along with this, you should also comment whether there is presence or absence of any additional lesions. That also has to be mentioned in the negatives. Then, Since this is a straightforward case, we can state it as the findings are consistent with chondroblastoma of the proximal humerus. So what is the management recommendation? So you will have orthopedic oncology review, and further you have to assess the lesion with MRI, and plan for biopsy will be the definitive, that is for the definitive diagnosis for further management. So next we'll see another lesion. Sorry, we'll see the cross-sectional images of this same lesion. So if you see this, you're able to appreciate the chondroid nature of the lesion where there is ring and arc calcification. So imaging modalities, X-ray is more than enough to diagnose or come to a differential diagnosis. Role of CT comes only when you have difficulty in identifying or appreciating the matrix of the lesion, to pick the cortical breach, or to analyze the fractures. MRI is mainly for local staging, soft tissue components, neurovascular bundle status, how is the extensions, all those things can be commented. You're not going to diagnose on MRI, it's mainly to comment about the extension, local staging, and the relations with other structures. And only in case of any dicey situations where we are not sure whether this is neoplasm, non-neoplastic, which we'll discuss in the pitfalls. So this is how a chondrogenic tumor appears. It will appear in usually hyperintense on T2, and it is very much well confined within the epiphysis and metaphysis, and there is no any extraneous soft tissue. And if you observe, we saw some endosteal scalloping. If you see the CT, there are few irregular defects which is picked up well in CTs than the X-rays. There is one advantage of CT. But on MRI, we are not having any significant extraneous component. So do you wish to add another differential, seeing the erosions here? Yes, definitely you should consider any low grade malignant transformation of chondroblastoma. So always, after seeing the radiographs, give a set of differentials. After seeing the cross-sectional imaging, if you want to add your differentials, add. You can mention as a chondroblastoma, going in for any low-grade chondrosarcoma transformation, or you can give just as a chondrosarcoma, secondary as low-grade chondrosarcoma, and eventually you have to do biopsy. So next case, so we'll see in a 40-year-old male patient with left shoulder pain. Now we are dealing with a age group of above 30. So most of the lesions, as I said, will be usually aggressive kind of lesions. And we'll see the checklist. So physis is fused. So we are dealing with a mature skeleton. It is located in the proximal humerus. It is both central and eccentric intramedullary lesion, predominantly in the epiphyseal subarticular location, and it is a lytic lesion. The zone of transition is narrow. There is chondroid matrix. There is hazy arc-like clumped mesh type of network of density, which is usually chondroid in nature. Your osteoid will be homogeneous, amorphous, cloud-like. If you see mesh type, these kind of hyperdensities, that usually signify chondroid mineralization. And as such, there is no periosteal reaction, but there is moderate amount of endosteal scalloping. So similarly, how you are going to describe, this is a frontal radiograph of left shoulder of a mature skeleton. There is a well-defined eccentrically located geographic lytic lesion in the epiphyseal region of the proximal humerus. It demonstrates a narrow zone of transition, contains chondroid matrix mineralization. There is moderate endosteal scalloping, how the cortex is intact. Then the negatives has to be mentioned. Findings are consistent with chondrogenic neoplasm of proximal humerus. At this point, I am not going to comment whether it is benign or malignancy, because I am dealing with a elderly patient, that is age group of in the range of 40 with the symptoms of pain. We are having a chondrogenic lesion which is epiphyseal. There is moderate amount of endosteal scalloping. So we have to give both the differentials of low grade chondrosarcoma and an enchondroma in this situation. So further recommendations will be MRI and plan for biopsy based on that. So we did an MRI for this case. So here if you see, there is cortical breach and some amount of extraosseous component seen here. On T2, it will be hyperintense. As I said, chondrogenic tumors will be hyperintense on T2. This is the pre-contrast image and this is the post-contrast image. You can see the extraosseous enhancing soft tissue component in this lesion. So the lesion has breached and come out, suggestive of an aggressive entity rather than a benign entity. So this is reinforcing your first differential of low-grade sarcomas. So this scalloping plays a very important role. If you see both the cases, scalloping on X-ray plays a very important role. This will tell whether the lesion is going for at least a low-grade transformation into chondrosarcoma. So this is what I was enforcing in the initial slide. So endosteal scalloping in a chondrogenic tumors plays a very significant role. So if there is more than two-thirds of the cortex being scalloped, then you are dealing with a low-grade chondrogenic neoplasm rather than a benign entity. So this is the take-home message for chondrogenic tumors. You have to emphasize on looking the endosteal scalloping. If there is obvious cortical breach, definitely it's an aggressive entity. If it is having very large soft tissue, definitely high-grade chondrogenic neoplasm. If it is having just breaches and a moderate scalloping, you are dealing with low-grade chondrosarcoma. Because the management for enchondroma, low-grade chondrosarcoma, and high-grade sarcoma is very different. So you have to be very careful with what you give the differentials. So final diagnosis was a low-grade chondrosarcoma. So next entity. So these are like usually these are minor cases. So we'll see the checklist. So there is an immature skeleton, and there is a lesion in the distal femur which is eccentrically located. It is in the metadiaphyseal region. It is lytic in nature. It is geographic with narrow zone of transition and thin sclerotic rim is seen. No matrix is made out. No periosteal is seen. There is severe endosteal scalloping. In lesion without a chondrite matrix, these just tell about the remodeling changes with the host bone is undergoing. But when you are dealing with chondrite lesions, we have to be very careful regarding the endosteal relations. So this is again how you describe. Those are the frontal and lateral radiographs of lower two-third of right thigh with knee joint of an immature skeleton, and there is an well-defined eccentrically located geographic lytic lesion in the metadiaphyseal region of the distal femur. The lesion exhibits a narrow zone of transition with thin sclerotic rim and no obvious matrix mineralization. There is severe endosteal scalloping, however, cortex is intact. There is no periosteal reaction, fracture, or soft tissue, or no other lesions associated. So findings are suggestive of an benign neoplasm. The differentials you can give as non-ossing fibroma, aneurysmal bone cyst, chondromyxoid fibroma. And how to, they will ask what are the features in favoring osteo non-ossing fibroma, aneurysmal bone cyst, and chondromyxoid fibroma. And you can state the differences. Chondromyxoid fibroma will have sometimes some chondrite matrix that is not there in our case. Aneurysmal bone cyst will be more likely an eccentric and expansile kind of lesion with soap bubble appearance, all those things. Here it's almost confined within the bone confines. And non-ossing fibroma can show these kind of typical eccentric in location, narrow zone of transition with a thin sclerotic rim image. So 1 to 3 will be your differentials, and differentiating features of each can be stated. And if it is pathologically, if it is a patient is having symptoms, most of the benign neoplasms, if it is asymptomatically detected, they will just observe. If there is any associated symptom, pathological fracture, all those things, then only they will intervene. So intervention will be usually for all these benign non-ossifying fibroma, ABC, GCT, all those will be curettage with bone graft when it is symptomatic. Asymptomatic, incidentally detected, do not touch the lesion, do not biopsy the lesion, just follow up those lesions. So last case we'll see is an aggressive kind of lesion. On seeing itself, you will be able to pick that it is an aggressive kind of lesion. So we'll go through the checklist. There is a immature skeleton, proximal tibia is involved. There is a central intramedullary mixed type of lesion. There is both sclerotic and lytic, and the lytic are usually like you are able to make out the permeative moth-eaten type, and there is a wide zone of transition. And mineralization, you are able to make out the dense, amorphous, hyperdense, or sorry, radiodense area, that is the osteoid matrix of the lesion. Then the periosteal reactions, you are able to make out the sunburst and Codman triangle and all. Then cortical destruction is there. Then even there is soft tissue components. So if you see anteriorly, there is a small soft tissue component here. So this signifies there is presence of soft tissue mass also. So all the radiographic features which we see look for aggressiveness are present, firstly of an aggressive entity. And in immature skeleton, metaphyseal predominantly epicentered lesion with the osteoid matrix. The lesion itself is telling it is having an osteoid, so you're looking into some osteoid containing lesions, that is osteosarcoma. But you can also give as a DD as a less likely Ewing sarcoma, and you can tell though these features are there, the osteoid matrix is the one which is striking in favor towards osteosarcoma, and this is how you describe an malignant lesion. So there is an ill-defined, centrally located mixed lytic sclerotic lesion in the metadiaphysis of the proximal tibia. The lesion is exhibiting wide zone of transition with osteoid matrix mineralization. There is cortical destruction with aggressive periosteal reaction. You can mention the types like sunburst and Codman's were seen, and adjacent exogenous soft tissue component is noted. The soft tissue component was just displacing the flat planes. It was not obliterating the flat planes anteriorly, and no other additional lesions are noted because osteosarcomas are known to have skip metastasis, additional bone metastasis are all possible. And DD, since it's a malignant young patients, can be wings, but the matrix favors in favor of osteosarcoma. So what next? This is in general for malignant neoplasms. So this one slide, if you remember, it will be easy to tell what next for a malignant. So if at all you get a malignant neoplasm, either it will be primary or secondaries. Primary, usually they will give solitary lesion. So if it is solitary aggressive looking lesion, either it will be osteosarcoma, Ewing's, chondrosarcoma. Based on your radiographic findings, you can narrow down to your differentials. So if it is more towards osteosarcoma, the next important step is MRI for local staging. Then subsequently you have to do PET CT with or without chest CT, because these osteosarcomas are prone to metastasize to lung. So they usually, at times, some centers along with the PET they will do HRCT recon. Some places they will do separately because HRCT will pick small nodules. And subsequently, after you are having the MRI and PET CT, then only the tumor board or multidisciplinary team will plan the biopsy. The biopsy will be planned such that during the excision of the lesion, the biopsy tract will be excised, because this biopsy tract is a prone to seedling. So that has to be planned such that you are going to remove the tract, and the surgical plan for the will be discussed by the surgical onco and the ortho team. Then only will the biopsy will be planned. So not like you are seeing some lesion, will go just biopsy and come. So it will be a multidisciplinary discussion to plan the biopsy itself. Then the management, once you get the biopsy report, they will start with neoadjuvant chemotherapy. After a few cycles, they will assess, a response assessment will be done with the MRI. Then again, they will do a chest CT or just chest CT, or along with it, they may or may not do PET CT. Then assess the response. Then go ahead with the surgery and adjuvant chemotherapy. So this will be the set of plan for your osteosarcomas. Ewings will follow the same set of rules. So they will have local staging, PET CT, because here, along with chest, bone mets are more common in Ewings, which we encounter. Then there will be neoadjuvant chemotherapy. Response assessment will be done, and using MRI and PET CT. Then you will decide whether it is amendable for surgery or radiotherapy, because Ewings can also occur in flat bones, axial skeletals like pelvic bones, all those things. So when they occur there, it's not very approachable for surgery. In those cases, radiotherapy is preferred more than surgery, then followed by adjuvant chemotherapy. Whereas in chondrosarcoma, the initial part is same, but the management is purely surgery. Only one or two types, subtypes of chondrosarcoma can respond bit to chemo radiotherapy. Otherwise, they are usually resistant to chemo and radiotherapy. So don't rate chemotherapy, radiotherapy for all three. Chondrosarcomas, at least you remember chondrosarcoma, chemotherapy, radiotherapy are usually resistant. The other two, we usually follow the same set of flowchart for management. So now we'll discuss few common pitfalls. So one is the overlook clinical context. So sometimes we'll assess the lesion, we'll describe everything, but we forget to check the age of the lesion. If an elderly patient is, you're dealing with an elderly above 50 and all, whatever the lesion is, always give the first diagnosis as metastasis. So you have to observe clinical context, whatever is provided for your case. Next is the great mimicry in young patients. That is an aggressive appearing lesion in a child, whether it is infection or Ewing's. So we'll see one by one. So overlook clinical context is just a clinical scenarios which you will encounter. So here is a case where there is a 19-year-old patient with a history of fever, pain, and swelling over right thigh. So if you see the history, whenever there is fever, pain, swelling, and all, you will think of infections. But you have to be aware that Ewing sarcoma can also present in the similar picture. Ewing sarcoma can also have fever. They also can have present with fever and pain swelling. So in this radiograph, you can see, if you see here, there is irregularity on the context, but if you apply all those things, there is permeative moth-eaten type of lytic lesions, which suggests it's an aggressive entity. There is a wide zone of transition, which again suggests it's an aggressive entity. And the periosteal reaction, here we are able to appreciate only a single unilaminated periosteal reaction, but there is cortical irregularities there on the lateral aspect, anteriorly unilaminated periosteal reactions. So the other features, the lytic nature of the lesion, that is permeative, moth-eaten, wide zone. This is telling that this is a very aggressive kind of lesions. So you can have at least one or two features which is showing aggressiveness. The periosteal can be aggressive or non-aggressive, but you pick the aggressive part and label it as an aggressive kind of lesion. And if you see the soft tissue, there is some bulge of the soft tissue and displacement of the fat plane. So we don't know whether this is a muscular bulk or there is any soft tissue associated with the lesions, because most of the lesion is in the distal diaphysis, mid diaphysis. We are not able to appreciate on X-ray. So in this kind of scenarios on X-rays, it can be Ewing sarcoma or osteosarcoma, or even in case of infections. So since it is more like a history of fever, pain, and all, we'll think of Ewing's and infections. So we'll preferably give both the details and proceed with MRI. So even MRI at times it is very difficult to differentiate, but we'll try to see at least 2-3 points. So if you see here, this is the pathological bone here. If you see, even the mid diaphysis is involved with the extensive soft tissue component. So this extensive soft tissue, extraocular soft tissue component, which was displacing the muscle, which we saw on the X-ray. And if you see the T1 weighted images, it is very well demarcated. So well demarcated on T1, extensive soft tissue component. On post contrast, there is a significant enhancement of the soft tissue component with some necrotic areas. If you encounter these features, it is more likely an neoplastic etiology rather than a infection. So how you do the infection appear? So see, this is a case, another similar case. You can see a lesion, and the adjacent soft tissue, there is more of a soft tissue edema rather than a soft tissue mass. So in that case, we are seeing a soft tissue mass. In this case, we are seeing only soft tissue edema. And if you see the T1, it is diffusely hypo. You are not able to differentiate a clear demarcation between the lesion and the normal fatty marrow in the T1 weighted image. And post contrast study, there are just soft tissue enhancement, but there is no any obvious soft tissue mass. So Ewing's versus infections, at least try to see soft tissue component, the presence of soft tissue mass or soft tissue edema in the T1 weighted, whether there is clear demarcation or whether it's diffusely hypo intense. So these are few things which will help in differentiating Ewing's versus infection. And finally, you have to suggest biopsy. So in exams, we are not expecting a definitive diagnosis. At least you can show you're good at the approach, define the points, tell the differentials, the next step, what you are going to do with the case. So next pitfall is similar to the what I told clinical context. As soon as you see the X-ray, epiphyseal lesion, destructive, locally destructive lesion, epiphysis in location, you will start thinking of GCTs. But age is 67. Always think of a metastatic lesion. So similarly, in this case, you are seeing some lytic lesion here. So juxtacortical in nature, narrow zone of transition, and there is no fracture, no periosteal reactions. All those, if you apply, looks like a non-neoplastic, non-aggressive lesion. But age is 55 and the patient has presented with pain. Always your differential first should be metastasis unless otherwise proven. So next, misidentifying the tumor matrix. As I said, some will start saying this as chondroid. No, these are like linear, mesh type, dotted. All these are like chondroid. Your osteoid matrix will be very dense. It will be dense, cloud-like, amorphous kind of density. So this is, you shouldn't mistake with chondroid and osteoid matrix anytime. Then you should see the periosteal reaction. Sometimes it won't fit any of the types which I have described now. So if you see here, there is thin rim of some tissue, some sclerotic area is there, some periosteal reaction is there. It's not like single unilamellated. It's not elevated to call it as a Codman's triangle. It's not multilamellated, but still some atypical kind of periosteal reaction is there. Even if it is not fitting, just mention as a periosteal reactions. Look into the other features which are contributing to your aggressive nature. Here we are able to appreciate the chondroid matrix, but we are not at all able to see the lesion. So there is a wide zone of transition. So this periosteal reaction, more than periosteal reaction, the wide zone favors the malignant nature of the lesion. And this, we have been seeing this case. Some tissues are seen here. Some pattern of periosteal reactions are there. So it's not fitting any type, but the lesion is aggressive in nature. So that is enough to tell that this lesion is more moving towards aggressive differential diagnosis. And you can just mention as in some atypical periosteal reaction. Next, don't get lost in the lights of an MRI. Don't just start seeing MRI first and then come to the X-rays. So if you see here, this looks like a bizarre lesion in the distal end of radius. You will be just shocked to see how the MRI images looks very weird and all. But it is just a simple case of GCT. Epiphyseal lesion, skeletally mature patient, subarticular location, it's a GCT. Your MRI is done mainly to look for the local extension, relations with the soft tissues, and what all are involved. So just don't get lost in the lights of MRI. It appears so bizarre, all those things, but to diagnose it, always see the X-rays. So this is the summary, the three pillars which I said: age at the presentation, location within the body and within the bone, where exactly it is located. Then the few radiological features which I mentioned, of which radio density and matrix states the histological possibility of diagnosis of the lesion. Then margins, periosteal reaction, cortical involvement, soft tissue, these tell the aggressive nature of the lesions. Then so if you club all those, you will be able to come to an proper diagnosis. Always go through the checklist. Wherever you are stuck, no, whenever you get stuck, go to these steps. State the age, try to pick the findings, what the bone lesion and the host bone is trying to tell you. State whether it is aggressive or non-aggressive. For that age group, aggressiveness, just give the DDs and tell the next what possible step you are going to do in that particular case. So final exam tip is be confident, be systematic, speak clearly. Even if you make a mistake, the examiner is more likely to guide you if you have demonstrated a solid fundamental approach, how we have done in the previous slides. So follow this and it will be very smooth exam for you people. So these are my references. So I would like to thank Dr. Rudresh Hiramat, my professor and former HOD. He's working in Narayana Medical College, Nellore. So he used to teach most of the things for me in entire radiology. And Joyce Upendra sir, so he was the first mentor for me during post-graduation residency, and Dr. Satyendra Raghuvanshi and Geeta Raghuvanshi madam and the radiology without years team. So my journey started, this exam preparation started with RWT. So I used to read that big book for practicals. So I thank them. And finally, I thank Jipmer Puducherry to give this opportunity and providing extensive exposure to various malignant or benign bony neoplastic conditions. Thank you.
Thank you so much, Dr. Gurumurthy. And due to paucity of time, we'll take around 3 to 4 queries. So if you have any query, please type in the box. We'll be happy to answer them. So I think there is no query. So on behalf
So I
of
have
everyone
displayed my
present,
email ID. Sorry, ma'am. It displayed my email ID. You can note down. Even if you have
yeah,
any doubt anytime, you can mail me the queries. Even if you have any doubt in any case with respect to bone neoplasms, you can share the X-ray. You can share the images. I'll be very happy to discuss those cases and guide you in preparing for exams or even for your clinical practice. Thank you.
okay. So on behalf of everyone present, I extend our heartfelt gratitude. Thank you to all the participants for joining and making this session meaningful. So with that, we'll officially bring session to a close. Have a wonderful day ahead. Thank you.